Good morning, everyone. So we are here for the first theme of the Global Forum on Bioethics and Research. And we have 3 case studies here. So before I get on, and a lot of the scene has been set by the speakers prior to me, and particularly the Pichakusha sessions, which were like really good. So we will start on with this session and the case studies. But before that, I just wanted to set a bit more of the scene around. It's more of us discussing things. So I have a question for you all. Please raise your hands if you believe the answer to this is yes. Okay, I see a few people are like, I don't know, like, maybe, okay, like, so, like the rest of the conversations might not be interesting if you feel this is no, but this is where the next part gets in, where does health research priority setting improve health and well-being of people? So you voted that yes, research does help improve health and well-being. What about health research priority setting? Okay. Like very few, okay, and I think this is where the challenge of this topic lies in, among the many other challenges which we will discuss in, is we know that health research improves health and well-being of people, but when it comes to health research priority setting, we need to evaluate them and understand that whether they are improving health and well-being of people. But this is particularly tricky, especially when we are doing very big national level priority setting. When we are doing for a research funder which is doing a health research priority setting and setting these are our priorities, then we are doing a particular set of funding. And they can a priori say that okay, these are the outputs we want from this particular funding call, and can evaluate somewhat the pathway to the improvement of health and well-being of people. Okay, but at a national level, this becomes quite tricky. So the question now is, who should set national level research priority setting? Does anybody believe that it's governments? Please, can you raise your hands? Okay, governments, okay. Okay, if you do not think it's government, who do you think you are? Like, please feel free to raise your hands and shout out. Okay, and this is a very interesting question, actually. I think Dr. Mona has something.
I think generally the question about who should set the priorities is a contextual dynamic question about who is at that moment the person who we need to include and who are the people we need to exclude. I think that's the reason James and Library Alliance is so beautiful, because they made a decision who to include, but also a decision who to exclude. So I think that depends who has been governing the research up to now and who should be governing the research in that moment, that future, which might change depending on the platform. So I don't think there's one answer.
Yeah, so as rightly said, like it's really contextual in nature. And through these case studies, we will see how there are different diverse case studies and different settings and contexts in which priorities are set. Another thing about government setting research priority setting is also the fact that governments might set their own research priorities at a national level, but that doesn't stop others to set their own research priorities, and especially in democratic and free societies, that's the norm. Everybody does set their priorities. They may or may not align with the government priorities, and there's a lot of power dynamics which plays in the place from national level actors, local actors, as well as international actors, and we'll see through these case studies and try to understand how things are there. And there are 3 elements of the FAIR process, and as you might have seen in the title, one is transparency, the other is representation and evidence. And this is kind of understood in terms of FAIR processes. We want transparency in the governance process, how priorities are set. We want representation of people who will be affected, as well as different stakeholders who are involved in the process. And we also want to look at the evidence around what is already known to inform the gaps which exist. So unless we know what is there, we can't know what are the gaps. But it becomes a bit challenging when we are going back to evaluating our priority settings, because it's not only about improving the health and well-being of people, it's also about distributive justice. It should be available to people based on their equity needs, and there are significant ethical and equity issues which we have to consider in the priority setting. And this becomes very challenging when you do at a national level, where there's a lot of aggregation happening and priorities often get drops. And so those kind of equity-focused analysis often is useful. And last of that is compensatory justice, which is essentially about historical wrongs that has been done, which needs to be compensated for. And there's a lot of aid-driven research, and that's how the world functions, unfortunately. And priorities are often set by governments because it's a funder requirement. A funder would only fund if there is a priority setting and some priorities have been identified. So it's often trying to fit in that bucket too. So the compensatory justice and the epistemic issues around justice do affect things even in the current world, though politically decolonization has happened globally. So that brings me to my last questions. Do governments have an ethical obligation to improve health and well-being of people? Okay, so that's a yes for everyone. Trick question, that was not the last. So do they have an ethical obligation to conduct health research priority setting then? Okay, so governments do have an ethical obligation, but they actually do not have a legal obligation to do it. And and the reason I put up this slide is I believe this is a very good forum for us to move the needle towards this direction, where among the bucket of health as a right, health research priority setting is also recognized there. And that's all from my end. We will go to the speakers now. And we have really good presentations from the three speakers. So the first presentation is by Dr. Suzanne Kiwanuka from Makerere University in Uganda. And I would welcome her to the stage. She will be talking about reimagining the ethics and the utility of existing frameworks for research priority setting, a case study of the family planning research and learning agenda in Uganda. Thank you.
Thank you very much. Good morning, everyone. I won't say much. I've been introduced. Thank you very much for the organizing committee and for inviting us to share our experiences from Uganda. Research priority setting has long been driven by disease burden, mainly focusing on the biomedical drivers of disease, and this has led to the neglect of non-medical determinants of health. And as a background to this case study, we wanted to enhance the ethics and reduce inequities and enhance justice in health. So we generated a research priority setting with a need to be participatory and inclusive and align our needs, or the researcher identified needs, with a wider audience. In Uganda, the Research for Scalable Solutions, the R4S project, currently in its last stages, was supported to develop research planning, family planning, research and learning agendas. This was done across 6 countries, including Uganda. And it was intended to enable these countries to systematically identify and prioritize evidence to be generated and used in order to inform family planning programming. So we wanted to also reduce duplication of evidence generation, but to enhance the use of what already exists by aligning stakeholder resources around our expected outcomes, that is to improve family planning uptake in Uganda. So this was a 2-year multi-stage process where we reviewed family planning evidence from 115 documents. And we also did a secondary data analysis of district health information data across 3 years, that is 2011, 2016, and 2006, to see the trends in family planning uptake. We also did multiple stakeholder engagements where we engaged stakeholders with the evidence and to get the evidence gaps. So that is a summary of what we did. So you'll see we reviewed the literature to get lessons and gaps. We also analyzed the secondary data. We synthesized both, and we came up with information which we shared with the stakeholders for an initial engagement, and we collected the additional programmatic evidence gaps. So we invited program leads to these meetings. We used emerging questions to conduct a Delphi panel and reprioritized more of these questions in order to synthesize, because we had a massive load of questions. We validated the questions following the Delphi panel, and we shared the final research, family planning, research and learning agenda with the Ministry of Health, which has already been uploaded to the ministry website. So this case study is a reflection of what we did in order to ensure that this work has beneficence of justice, inclusion, and use for the research agenda. As you heard earlier, it's important that this research priority setting is useful. So in terms of beneficence, we tried as much as possible to align priorities of this research agenda to already existing agendas. So we ensured that these research and learning agenda aligned with the local priorities. We applied the global priorities to the local needs, and we tried to look at what the global targets are. When you look at the global targets, there is persistent gaps in youth, there is persistent gaps in the impact of social norms as a barrier to access. And this also came out very clearly as we were trying to map the data. We also tried to align this research and learning agenda to the Uganda's 2020 priorities, and it was later mapped onto the National Sexual and Reproductive Health Rights Policy, which aims to promote research to achieve national objectives for sustainable development goals. This research and learning agenda also complements other policies within the country, such as the reproductive health policy, the maternal and newborn and child adolescent health policies, as well as the sharpened plan. But we can have more discussion on that. So in order to make it more beneficial to the public, we did this extensive literature review and secondary data analysis, which helped us to have an entry point of discussion for our stakeholders. So we were able to know that there is a lot of evidence in this area, but there is gaps here. And we were able to interrogate why the evidence has not been used in programming. So the secondary data analysis exposed the trends across access to family planning performance nationwide, and it yielded valuable insights on inequities, such as the low uptake among youth, the regional differences in unmet needs, as well as varying access to family planning information, which was very useful for the programming people. It also enabled stakeholders to interrogate these evidence gaps and what evidence is needed to fill in. Therefore, this started a priority setting process with a lens towards setting priorities that are beneficial. And this exercise also facilitated our defining key priority needs, which were around enhancing self-care, boosting high-impact practices, and young people, as well as equity. This family planning, research and learning agenda tried to enhance the use of this priority setting product. The Ministry of Health, which was the lead organizer of most of the stakeholder engagements, owned this document and has currently uploaded it since 2002. They uploaded it onto their website for sharing with the funders and any researchers, students who want to do research focused on family planning. And we monitored this use because we embedded monitoring and evaluation tool within the process. So an online survey conducted this year revealed that this research and learning agenda has actually been used by multiple sources. They have been using it as a source document to inform program design, to inform research questions and others. So we did this survey early this year. The respondents, 104, have revealed how they have used this document, which they have had access to via the Ministry of Health Knowledge platform. So we found that this was a very good thing because it's not just a document, but it's actually already being used. In this process, we included a lot of stakeholders in order to enhance the inclusion and ownership. And as you can see, of course, we had a lot of people from academia. We had a lot of people who were policymakers. And we had fewer people from the users of the document. Of course, we appreciate the beneficiaries of this stake. And that was perhaps one of the issues which could have been done better. And so we felt that our multi-stakeholder participation has improved the justice which we can achieve through this process because it has focused priority questions towards aligning, but also decolonizing those research priorities from external drivers. I have to say that as a background, the team from the research project, the US funders, wanted us to focus on particular priorities. But by bringing this to the Ministry of Health and the program people, we were able to remove some of their priorities and actually build in some of the priorities for Uganda as dictated by our policies. This process was country-led. It was dominated by program implementers, policymakers, and academia. And the inclusion of stakeholders from education, youth, sports, gender, we felt was very good because reproductive health is a multi-sectoral issue in the country. And we also tried to align this process to the total market approach, which emphasizes collaboration of multiple sectors in order to improve family planning uptake for all segments of the population. So what worked in our process? We felt that having prior evidence mapping to elicit gaps provided an entry point for us to engage the stakeholders because we were able to tell them that this already exists. Can we look at what we can focus? The second was the inclusion of programmatic evidence. The third thing we felt worked was the multiple stakeholder participation. These were legitimate stakeholders who fostered ownership and then alignment to country priorities and targets, and finally monitoring use. What do we feel did not work? I think we overlooked the segment of people with the lived experiences, the members of the public, and we did not include very well the research funders who are actually looked upon to fund this research. We felt that there should be greater representation of the cultural and religious leaders because family planning is a very cultural and religious issue in Uganda. And of course, underlying all this was the persisting tension between the global priorities and our local needs. So it's important to have the multi-stakeholder involvement to monitor the use of this agenda. It should be a key concern. And it should be country-led to build this capacity, and evidence should be mapped to reduce duplication. And finally, to include the research funders. Thank you very much.
Hello. Okay. Okay, does anybody have any burning questions for Suzanne?
Yeah. Hello, I'm Florencia Luna. It was very interesting, your presentation. I wanted to know more in detail, you said that there were priorities that the funders had and priorities that you could implement or put up. So what were them exactly?
Okay, so the funders came in with a research project which had already been streamlined to focus on particular things with funding budget lines already aligned to those particular things. But part of the process was to generate a research priority setting agenda. So we found that our priorities were less budgeted for than those priorities already existing within the already approved budget. So what happened is that we were told to share this with Ministry of Health so that the Ministry of Health can lobby for funding for these priorities, which we found really important. So there was still that tension. We failed to get them to shift their budget lines towards the priorities which emerged. Instead, what we succeeded in doing is sharing this with the Ministry of Health so that other funders there can know that these are other existing priorities. So I could say that the funders who were doing this project already had an approved budget with budget lines on what research work they wanted to do. And I think this is not new to many people in this room.
Okay.
You could change, but not as much as you wished. Finally, it was the government that came through. But you had the help of doing all this exercise and being able to show the government what were the needs.
Absolutely.
Thank you.
Okay. Everybody else, please hold your questions. We are not letting Suzanne run away. We will have more time for questions after the three speakers have presented, and then you can probably have compare and contrast and ask more nuanced discussions. Thank you, Suzanne. Okay, so our next speaker is Dr. Ramón Ponce from the Pontifical Catholic University of Peru. And he will actually be talking about the assessment of the priority setting exercise for health research in Peru. Thank you.
Thank you. Well, hello to all, and thanks for being here. Well, I will talk about the priority setting exercise for health research in Peru from 2014 to 2018. This case study was prepared by me and by Sara Carracedo, who is sitting right there. Well, our aim is to discuss some ethical points regarding this case. I will try to follow these steps in my presentation. I will give some fast background, then present the case, and finally go to the ethical issues. Well, the idea of doing or bringing about an exercise of priority setting concerning health research problems is not new in Peru. In fact, you can trace back these ideas or efforts maybe to the late 1970s, but it is not until the early 2000s that the institutional capacity to carry them out became apparent or feasible. So from the 2009 or around the end of 2000 onwards, Peru has had two exercises of priority setting for health research. The first one was carried between 2009 and 2010 and established priorities for 2010 till 2014. And the second one was carried out from 2014 till 2018 and established priorities for the period 2019 till 2023. One parenthesis, my screen is not working here, sorry, this one. Meanwhile, you may notice, yes, this screen is not working. Meanwhile, you can notice this messy reference to years. Notice that the first reference implies the years that it took the process to be carried out. And the second reference to years comprises the period for the implementation of the priorities previously identified. Thanks. So our case study is the second one. So this exercise had 3 stages, and each stage had different goals and maybe also different methods. So the first stage aimed to identify health research priorities in all the regions of Peru. There are 24 regions in the country. The second stage aimed to prioritize regional health problems. That is, once the process had identified health problems and priorities in each one of the regions, then you had to try to prioritize or synthesize those priorities into one basic list. That's the second stage. And the third stage tried to consolidate a final list of priorities within this basic list. So let me say something about each one of these stages. So the first stage worked mainly through workshops. It is through roundtables with participants and trying these participants to be as plural as they can. There can be maybe some questions about this, but it worked through workshops, and the roundtables basically deliberated about the priorities of each region. The final result of stage 1 was that the country had 24 different lists of health research priorities. The second stage aimed to, as I said, to synthesize or to translate, to say it in some way, these 24 different lists into one basic that is nationwide. And OJIT, which is the main agent of this process. OJIT is the General Office of Research or for Research and General Transfer. It has changed its name some weeks ago, but it's been 15 years that it's known as OJIT, so it's OJIT. So OJIT implemented a virtual consultation, a platform, and through this platform, OJIT consulted experts on how to synthesize these problems, these multifarious health problems and priorities according to each region, into one basic list. So 174 experts or public health experts work on this, give their advice. And their advice basically was a ranking following some criteria on which problems were more important or required more priority than others. So the result of stage 2 was a list of 21 health national problems. And with this, we go to the final stage, which is stage 3, which, as I said, try to consolidate health problems into a list of national research priorities. In this stage, once again, the process used workshops. And in this case, there were not 24 different workshops in each one of the regions of Peru, but one basic national workshop. The workshop was mainly deliberative. 118 participants divided in 10 working groups worked for 2 days. And they used 3 criteria for prioritization: knowledge gap, feasibility, and consequences of research. They assigned scores to each health problem following these criteria, and the final result was 58 national research priorities that responded to now 10 health problems. So we raised some ethical concerns about this exercise. They have to do with governance, with inclusion and fairness, and with transparency. First of all, governance, and our main issue with governance has to do with how the process manages time. There are other governance issues that are important, but time here is our focus. First, we recognize the great efforts of the OJIT and the National Institute of Health in doing this process, but we find some ethical issues that need to be attended. So, if priority is time relative, one priority can be identified in time A, but in time B, that priority may not be a priority anymore. So we believe that priority is time relative. If priority is time relative, what should be the most suitable relationship of the exercise with time? And here are some things that need to be considered. This exercise took 4 years to its completion, but if you compare it with the previous one, the one that was done between 2009 and 2010, it only took 1 year. So what is the most suitable time you would need to do a good process of priority setting? Here it's 4 years, but the previous one was 1 year. There is some inconsistency there. Second, the application time frame, or the time frame for the implementation of these priorities. It is 4 years in the case of Peru, but why 4 years? Why not 3 years or 2 years? And if it should be 4 years, what are the reasons for these 4 years? There is no information about how they reach this conclusion or this decision. And finally, if you checked, maybe you don't, but if you check, there is a vacuum between the first period of implementation and the second one. Between 2014 and 2018, there is a vacuum of priorities. Why is that? So what is the aim of a priority setting exercise if time is so loosely managed? This leads us to inquire how independent is the exercise with respect to contextual pitfalls, and we would think that institutional weakness is not the only one, but it's a main reason to be an obstacle to do this right. Considering the stakes, we believe that this is a paramount ethical problem. The second problem has to do with fairness and inclusion of stakeholders. Even though the process to set research priorities at the regional level is driven by a participatory approach aimed at reaching consensus, we believe or have some concerns about their adequate involvement. how does the exercise preserve the integrity of the regional participatory consultation of stage 1 with the independent work of OJIT and the technical input of public health experts from stages 2 and 3? Why is it that most of the people involved in different stages of the process were MINS officials and subject experts? The selection criteria, on the other hand, to decide who attends the national workshop of stage 3 are rather obscure, or in fact, they're inexistent. Maybe there are good reasons, but we don't know what the reasons are for inviting some representatives and not others. And finally, transparency. The goal of OJIT to lead a transparent process of priority setting in health research is evident. OJIT has developed guidelines for each stage of the process, which are publicly available through its website, but we have still some concerns about transparency. There is not enough transparency about how the priorities are to be set, the coherence of the procedure with the methods and criteria it uses in their different stages. Transparency concerning this is paramount for publicity reasons and for credibility. Because the priority setting exercise aims at public reasoning to some important extent, the process should be publicly accountable to those involved. It should be as transparent as it could be if it aims at being effective. If the health research priorities list is not trustworthy for stakeholders, it is unlikely that researchers would adopt it. And one thing important here is that, for example, the participation of actual researchers during these two processes is quite scarce. This is even more relevant considering the low credibility of public institutions in Peru. Thank you very much.
Thank you, Ramón. Does anybody have one burning question for him? Yes, please.
Thank you, Ramón. This is a question to clarify something that, so you said that the criteria that were used were knowledge gap, feasibility, and consequences. Was there a definition of consequences?
Not that I know. I know that they used some programs or some approaches that are known in priority setting exercises. They use the 3D combined approach of Gafar and Alt. They use some papers and approaches from the World Health Organization. But if you check the information of the justification for methodology, there is nothing more than consequences. So you will have to interview the actual participants in the process, something that we aim to do, to actually know what was the interpretation or the approach to this virtual definition.
Thank you. We'll get opportunities to ask questions to the speakers again. Thank you, Ramón.
Thanks.
Please give a clap. Okay. Our last speaker is Dr. Sibongile Kaphaizi from Ministry of Health, Malawi. And she will be talking about balancing ethics and stakeholder interests. Thank you.
Sibongile Kaphaizi has already explained. I did this case study together with Billy Nyambaro, who is at the back. And the focus of the case study was on the National Health Research Agenda for Malawi, the issues that he made. As a disclaimer, these are our views.